Aloha, everyone who just joined. My name is Tish. Hi, we have Lani Weigert joining us today too. Again, to just let everyone know that this presentation is recorded for quality and training purposes. If you could please leave your video off for privacy. We are going to be using the chat box for any questions that you would like to ask. If you are unable to use the chat box, at the question and answer section of this presentation, we are going to allow everyone some time. You can unmute yourselves and ask questions. And we are just going to navigate this as much as best as we can. Thank you.
Hi, everyone. Thanks so much for coming. I see all of your names, but no faces. So it's so secretive how these are. But we didn't want to have all of the different boxes show up like the Brady Bunch, because there could be a lot of boxes up there. So we just wanted to make sure that, because some people are kind of shy and they don't want to show their photo, or they don't want to be on the camera, and that's completely fine. So we're just gonna have everybody stay off their video, and whenever they wish to say something, they certainly can unmute themselves and say something if they don't want to type it in the chat. Like for me, sometimes I can't type it in the chat because I'm not fast enough. So I'm just letting you know that option will be available to you. We're still waiting for people to enter, but I'm so glad that you've taken the time to join us today. We're very excited to have Dr. Dolan visiting with us today. You'll be able to ask Dr. Dolan today. That will be our featured guest, and we're so excited that she's going to be coming to us directly from her medical practice. And she's just going to take a moment away from her patients to be able to join us on our Zoom presentation today. Tish, did you have more people that?
I do not have any more people in the waiting room. It is 9:01. We can go ahead and get started. But before we do that, I do just wanted to let you all know that today's Zoom meeting is being recorded, so you and others may access it in the future. By keeping your video on, you are consenting to being recorded. If you do not wish to be recorded, please turn off your cameras at this time. Again, this is also for training and quality purposes. All right, so again, just wanted to thank everybody for coming. Happy Aloha Wednesday right here in the comfort and safety of your own homes. And we are so happy that everyone is able to join us. Lani is going to give her presentation, and at any time during the presentation, if you have any questions, you can enter it into the chat box. I'm going to go ahead and keep a watch out for that. If you are unable to access the chat, you can go ahead and raise your hand or simply unmute yourself. I know some people are calling in through their cell phones. Unmute yourself and ask a question. Just go right ahead. Without further ado, I wanted to introduce Lani Weigert. She is our Clinical Relations Manager at Hawaii Care Choices. Welcome, Lani.
Yay, thank you so much, Tish. And Tish, as people are coming in, would you like to have me wait for you to allow them in, or how would you like to do that?
It's okay, Lani. You can go ahead with your presentation. I'm going to give them a little chat before they enter and let them know the presentation has started, and a little bit of just what I went over. So you are all good.
Okay, perfect. Yay. Okay, aloha everyone. Hi, I'm Lani. I am, as Tish said, Clinical and Community Relations Manager as well. I'm honored today to bring to you information about our program. Some of you may have already heard this presentation, although there's so much information that oftentimes it's hard to soak it all in. So I really commend you for taking a second whack at this, because it's really important to understand all of the different programs. There's so much. So the three main programs that I'm going to touch upon today, which Dr. Dolan will also be able to touch upon, are palliative care, which is including our Kupu care, and hospice care, and then bereavement care as well. So I want to just jump right on into the deep end of the pool and just start explaining to you what palliative care is. First of all, I know that a lot of you probably don't normally hear that word palliative unless you're in the healthcare industry, but many people don't really understand what it is. So it is a special type of care that really focuses on people who have serious and life-limiting type of illnesses, such as cancer, COPD, congestive heart failure, or kidney failure. And what happens is palliative care is called for particularly to help relieve the symptoms of these illnesses, largely because these illnesses often come with treatments to either try to reduce the effects of the illness or to actually cure the illness. So in any case, there are some real discomforts associated to those treatments. And the kinds of treatments I'm talking about is, say somebody has cancer, you know, the treatments that someone might get from that would be maybe radiation, maybe chemotherapy. And so the type of discomfort I'm talking about associated with those types of treatments could be pain, fatigue, nausea. There could be other symptoms that really prohibit people from leading a very robust and full life. And so when people have us come in to do palliative care, it is so that we can help boost the quality of life for not only the patient, but for the family as well. And it is about bringing relief of these symptoms. Now, who would be appropriate for palliative care? Actually, anyone that is dealing with a serious illness, such as the 4 illnesses that I mentioned. And for patients of any age that might be dealing with it, they would also be appropriate, and at any stage in their illness process. So oftentimes when people don't have any symptoms, they think, well, there's no reason for me to get palliative care yet. But in fact, it's better to come on as early as possible. So people who are dealing with these serious illnesses such as cancer, COPD, CHF, and kidney failure, they may continue to have their treatments even on palliative care. So people have them in relationship to the two. So what happens is that somebody may be having chemotherapy and they still can come on, and we would help them deal with their pain and other symptoms that they may be having, largely because they're doing chemotherapy. So anyway, before palliative care even came onto the scene, people just used to suffer. I mean, just really be in pain all of the time, chronic pain. But now, with palliative care, the focus being on relief so that we can boost the quality of life for our patients and their families, it's a wonderful type of care to sign up for. Anyway, patients do not need to be terminally ill for this type of care. In other words, a person doesn't have to have a 6-month life expectancy diagnosis from their doctor in order to sign up for palliative care. Someone just dealing with a serious illness is a perfect candidate for this type of care. Also, the signs that palliative care is needed. So a lot of times people are unaware, like, do I need palliative care, or when should I sign up for palliative care? First of all, if you notice that you or a loved one who has a serious illness tends to either call their doctor often, and when I say often, I'm saying like several times during a month, maybe even in a week, or maybe visiting the emergency room on a regular basis. And it could be, several times during a 3-month period. That would also be a sign that palliative care is probably needed. Anyone that has difficulty managing their medications might be somebody that would be a good candidate as well. For the most part, physically, you can see when someone's diminished activities of daily living start to show, meaning they no longer can manage their finances. Driving becomes difficult. They don't want to go to the grocery store because they're either too weak or frail to do so. Preparing meals, they're not able to do that. Oftentimes they have a loss of appetite as well, and it's difficult for them to do light housework. I mean, vacuuming is like sometimes way out of bounds. I mean, in fact, it's out of bounds for me sometimes too, but that's, I'm sure, by choice. Anyway, so those who are dealing with pain, fatigue, swelling in the feet and the legs, and those who are dealing with nausea as well, those are definite signs that palliative care may be needed. When should somebody sign up for palliative care? When should it begin? I would say, and I know Dr. Dolan will say that too, that is at the time of diagnosis. A lot of times people will say, well, I'm not having any symptoms, so why should I sign up? My thing is that it would be better for you to sign up and already be at poolside, ready to receive care when it's needed. And what happens is it just gives the palliative care team time to get to know you, even though you don't need their direct care yet. When symptoms occur, say after maybe several weeks of chemotherapy, or going to dialysis for several months, and then you start to feel the discomfort, your palliative care team will already be part of your plan, your care plan. And it's just easier and a smoother transition if you go ahead and enlist the palliative care team as soon as you know of your diagnosis. The more serious your illness, the better it may be for you to sign up early, because oftentimes palliative care is definitely able to boost the quality of life. And when people are happier and without pain, they tend to live longer and happier. What to expect when you sign up for palliative care? So this is the other thing is, as I'm telling you all of these things, and I'm just like ripping through this because I'm so excited that Dr. Dolan's going to be joining us. If you have a question, go ahead and unmute yourself and say, Lani, I have a question. Then I'll stop and go ahead and answer it as we're going. Because if you're anything like me, I forget the question by the time the presentation ends. So do not hesitate. Go ahead and unmute yourself and ask the question. So let me continue. What to expect when you sign up for palliative care? Well, first of all, our nurse will come to your home, and that's wherever you call home. And the nurse will come to evaluate your health and medical history. For the most part, the nurse is really concerned about what's your biggest concern, because in palliative care, we serve the needs of the patient first. So it's a different approach to care. It's like palliative care is like the human side of healthcare. Like, we put the patient and their needs and wants first, and then dealing with the illness second. And that's how palliative care has really come on the scene, where, it's helped people not only enjoy their life better, but have their quality of life boosted by having palliative care. So the nurse will come, she'll get your health and medical history, and then she wants to know what your biggest concerns are at this point. And so the kinds of concerns she'd want to know or he'd want to know about is, what you're looking forward to. And you may be looking forward to, I want to go on the family vacation with my grandkids to Disneyland. I want to be well enough to go to a football game with my grandson. I want to be able to take a island tour around the island at the end of the month. Just things like that. Or some people will be super basic and simple, where they'll say, I want to get off the couch and be able to walk out to my mailbox and get the mail without becoming completely breathless. So those are very, very real wants and concerns. And our palliative care team would actually create the plan of care based on all of these wants and needs. So anyway, we're there. The palliative care team will educate the patient and their family. And why that's so important is because oftentimes a lot of the discomfort comes from the diet that we eat. So, if congestive heart failure is the challenge that we're dealing with, obviously eating Spam every day is not really going to help. So it's those kinds of things where people probably know, but it helps when there's somebody else trying to guide you. Medication review is one of the tasks that the palliative care team will be looking at. And the reason that is because by this time in someone's life, they don't only have their primary care doctor, they have their cardiologist, they have whatever ologist out there. And if they've had to go to the emergency room, then they've seen a doctor there as well, or maybe even urgent care. In any case, wherever they've gone, they have had a prescription of some type given to them. And so when they come home, they have medication from their primary care, from their cardiologist, from the emergency room, from urgent care, etc. And all of this medication ends up on their coffee table or their kitchen table, wherever they put it. We've gone into homes where people will have more than 50 jars of medication. And what happens with that is half of the medication is expired. Some of it belongs to their deceased ex-husband. Others belongs to their adult children that no longer live with them. And then there's a very small amount that is actual current medication that they're supposed to be taking. However, nobody throws away any of that medication because it costs money. And oftentimes we find that patients or their families will do the novice diagnosis of, the reason my neck hurts is because of this. And last time Dorothy was here, she took this medication, so I think I'll do that too. There is a great danger in that, but many people don't realize it. And when we come to the homes to evaluate what the situation is, we find that many people are just keeping their medication, and they could be taking up to 30 different medications each day, which is a lot of medication. And once we get in there and take an inventory of all that medication and let the primary care physician know this is all that this patient is taking, normally the primary care physician will say, okay, this is what they should be taking, and go ahead and put all the rest away, and we will. And maybe at that point, the person is taking 18 medications, which is still a lot, but it's a lot less than the 30 medications they were taking initially. And sadly, in the healthcare industry, many doctors are not saying to the other doctors what they're prescribing. So what happens is we have all this medication coming in from all these different doctors, and nobody is taking a look at it all at one time. We find that once the medications are reviewed, the symptoms of discomfort start to recede, at least by 10%. So it's a very important task that the palliative care team has with regard to medication. Tish, did you have something? No. Okay, we're moving on. So how does palliative care work? All right, so as I told you before, the focus for palliative care is always, always going to be on relief. The reason that palliative care is needed is to provide relief of pain and discomfort to anyone dealing with a serious illness. So there's other symptoms that occur with regard to serious illness as well. And it's not only physical. There are emotional uh, stresses that happen with regard to palliative care as well. People feel fearful. They may have anxiety. And of course, there's times where they can't sleep at night. And there's just a lot of different emotions around serious illness. We're able to come in with the team and help with that. So we would have our registered nurse come in as well as our social worker, and together they would figure out the plan of care for a patient. They would also help with the care coordination with regard to where the patient is going to go. Many times the patient will go to see their primary care physician, but then they have other doctors that they're going to see. Say if they're dealing with cancer, they're also going to go to their cancer clinic as well. All of that takes coordination. The other thing too is in creating the plan of care, we often like to deliver that information to the different doctors that are part of the team. And we become part of the primary care physician's team as well. We become an extension that sees the patient at home and then communicates to the doctor what's going on. Sometimes our nurse will accompany the patient to the physician's office. And the reason that happens is, number one, the patient may ask them, can you come with me? Because I really don't understand everything my doctor is telling me. Or number two, we're going to help the patient explain what's happening at home, which the doctor is not familiar with. Basically, when most of the patients want to be good patients, they'll come in and they won't really ask any questions or say much. They come in for the 7 quick minutes, get their checkup, and don't say a word. Well, when the nurse goes with them, the nurse will say, well, Mrs. So-and-so, would you like to tell the doctor about your fainting spells in the evening when you go from the bed to the restroom? Or maybe we should tell the doctor at this time about the number of falls that you've had at home. All of these things are so important to the care that the doctor provides for a patient, as well as for the palliative care team. So that kind of communication is very, very important. And having everybody be on the same page is paramount to giving the top level of care to the patient. Also, our social worker is able to help with not only getting an advanced healthcare directive for the patient if they don't have one, but also helping them fill out any of the insurance forms, particularly if they need to sign up for Medicaid because they qualify now. Then the social worker is able to do that, in addition to connecting them with other community resources that are available to them should they need different help within the community, such as being connected to the food basket or other services in the community that they may need at home. So all of this is happening because there's a palliative care team and because there is a plan of care for each patient that we have on the team with us. So how is palliative care paid for? This part is really interesting because it's not a cut and dry type of situation. Portions of palliative care services are paid for by private insurance, such as HMSA, Medicare, UHC, meaning United Healthcare, and Medicare. There could be a co-payment of $20 to $40 if a patient is not covered by both Medicare and Medicaid. So sometimes, depending on when our provider, either our physician or our nurse practitioner comes to visit, there could be a co-payment along with our licensed social worker. So sometimes that does occur, but we would tell the patient well in advance before that happens. Now I'm going to move over to hospice care. Does anybody have any questions regarding palliative care at this point? No, okay, we're just rolling right along. Okay, so what is hospice care? First of all, hospice care is part of the palliative care family. So it is focusing on relief, but more so it focuses on comfort. And for hospice care, there is a philosophy difference, meaning there isn't a focus on, just treating the disease. It's again, like palliative care, kupu care, it's about focusing on the needs and the wants of the person. Also, it's always going to be about the quality of life versus the quantity of life. Sometimes people will say, well, if mom's going to live longer, then we'd like her to keep having that chemotherapy. Even though her quality of life just diminishes so much, the trade-off is very, very clear. And for hospice care, that's where people have a choice, where if that's not what they want, if they don't want to diminish their quality of life by continuing to have treatments that are so debilitating, hospice is such a wonderful option for people. Also, what hospice does, the whole purpose of hospice, is to ease terminal suffering. And that means that there is so much other pains and things going on, but people don't want to sign up for hospice because they think that hospice is for a whole nother reason. But no, the main reason is to ease terminal suffering. And by signing up for hospice, death is not a requirement. So that's very, very important to understand. A lot of times people think that, oh, if I sign up for hospice, that means I'm giving up hope. No, it's actually that you're redefining hope now and focusing on all the loving time that you have with your families and all of the time that you'll be comforted and feel comfortable with regard to spending that time. So your quality of life is number one priority at that point. Having hospice care also really eases the emotional stress of having such a serious or terminal illness at that point. So although hospice is part of the palliative care group, it really does focus on comfort versus relief. What is hospice care? So hospice care, I explained to you, is a specific philosophy of care. And hospice care is provided by a care team to the terminally ill patient. So as you can see, there's a whole team, meaning there's the nurse, there's the physician, there's the spiritual counselors, volunteers, and oftentimes our spiritual counselors will also be the grief counselors if that is necessary as well. And then there's the social workers, there's the home health aides. I mean, there's a big team that comes out for hospice care. And for the most part, hospice care not only supports the patient, it supports the family as well. I tell this story of when the doctor told us that my mother was able to get hospice care. And a few years previous to that, my father had congestive heart failure, and his only wish was to pass at home. And we thought, as his children, that is a piece of cake. We can handle that. But sadly, what happened is one evening he couldn't breathe, and so we called 911, and he headed out to the hospital. And by the time we got to the hospital, he had already passed. So that was an epic fail for the family. And we just thought, how could we have eliminated that from happening? We had no idea. So as years went on and my mom was diagnosed with lung cancer, her doctor said to us, oh, by the way, your mom can have hospice care at home now. And we said, well, what is that? And then he explained to us that everything was going to be included for her with regard to all of her hospital bed, her medications, etc. She would no longer have to get in the car and come to visit him. She would be kept comfortable at home. And when we asked her, or when we asked him, well, how is that going to be paid for? He says, it is 100%, not 90%, 100% covered by her Medicare. So anyway, we went home. My brothers knew that there'd be no way that she would be interested in having hospice care, because she was just a very proud, stoic Hawaiian woman, and she would consider that a sign of weakness to sign up for something like hospice care. In any case, I went and broached the subject with her and said, Mom, so this was my conversation that I was having with my mom. So I'm sure it's going to be different for any of you out there when you have the conversation with your loved ones, but this is how mine went. And I said, so Mom, I heard you can get hospice care. And she said, hospice care? Oh, I don't need that. Oh, I'm not going to die for years. I don't need any of that. And I said, oh, okay, so you're not about hospice care. She goes, no, I don't even know why you brought it up. I don't even like the name. So I said, oh, okay. Well, it's too bad, Mom, because I heard that, they would come and give us everything for free. She said, for free? Oh, like what? And I said, well, they will bring all the medications that you need for your diagnosis now. They will bring all of the equipment, your oxygen, your hospital bed, everything. All of it is included. Oh, that is some kind of gimmick. You shouldn't believe that. I know they're going to send us the invoice later. In fact, who's going to pay for that? And I said, well, the doctor said Medicare pays for it, Mom. And she says, oh, no, the government? Oh, gosh, no, the government never pays for anything. We always have some kind of copay. So I said, well, you might be right there, Mom, but, would you like me to just check? I mean, gosh, if we can get it for free, why don't we just go for it? So she says, well, yeah, I mean, if we can get it for free, go find out if, it's some kind of gimmick. So, of course, that afternoon, all of the stuff came in. Her bed, things that she was not even using or needing to use yet, all of it came in. She could not believe. She says, oh, my God, I can't believe that this is all included. And I said, yes, Mom, this is all included. And so she says, well, who's going to come to the house? I don't like people coming to my house. I said, I know, Mom. So, it'll just be the nurse in the beginning. And if you like the nurse, then, then the other team members can come. But I heard, you can get your hair cut, they can do your nails, everything. If you want an extra bath, you can have that. She goes, oh, really? And that's all included? I said, yes, that's all included. So we continued on. We found out that not only did the hospice team come in and help her, and in fact, she had a 6-month life expectancy at that point, and she lived for 10 months. So we knew it was from the wonderful, concentrated, focused care that she received from her hospice team. And we also received quite a lot of support and guidance as well, because the trained volunteer would come in, they would read the Mormon Bible together. They would, in fact, have the home health aide come in and, spruce her all up. So she felt good. So she felt really happy, to be alive. And it's really about living. And that's why we thought it was so wonderful to have them come in. And then every now and then we would have the social worker come in, just check in. Really, these were her social group. I mean, they would come in because she was doing quite well on hospice care, and they were coming in to visit her. In fact, those were her main visitors besides us, her family. So it was really incredible. And when a few months went by, she said to me, she says, oh my goodness, I'm so sad that Daddy didn't have any of this. Why didn't we get hospice care for Daddy? He could have been at home and passed it home just like he wanted to. And I said, because we didn't know. Our doctor didn't tell us, so we did not know about this wonderful service of hospice care. And then that's when she said, well, I want you now to go out and tell all the neighbors about this wonderful care, because they're not going to know. They're going to be just like daddy and not get it. And look at how much they're providing for me, and it's all included. I said, that's a wonderful idea, Mom, but I think it's kind of awkward for me to go around in the neighborhood right now and ask people if they'd want hospice care. And she says, well, you just figure it out, okay? I want you to figure out how you can tell people about this hospice care, because I can't imagine people going through life and not having this wonderful care at end of life and having it all paid for as well. And so that's why I tell you, my friends, that's why I tell you, I don't do this as a job. I do it because I promised my mom I would. And so now I deliver it to each and every one of you that's on this call as well, because it is that important to me. So now, who qualifies for hospice care? Basically, anybody who is suffering from a terminal illness. A doctor, the primary care physician, normally must make their best guesstimate of whether or not a patient has 6 months to live. And the patient that decides that hospice care is for them will no longer want any kind of curative treatment, such as dialysis or chemotherapy or radiation. They are just looking to be kept comfortable at home with their family. When is it time for hospice care? Well, many times you can tell when somebody physically is going through a change. They have multiple visits to the emergency room or doctor. They tend to be losing weight. You know, they have a loss of appetite. They're very frail too and weak. So they may have increased falls. They don't tend to drink or eat very much. They have difficulty getting out of bed. A lot of times they just stay in bed most of the time, or it may be in a chair. If they're in a wheelchair, many times they just fall asleep in the wheelchair because they're unable to stay awake. And they tend to have recurrent infections and skin breakdowns as well. All of these things I share with you because these are things that you can physically see somebody is going through changes like that. How does hospice care work? Well, basically, we have a team that comes out to the patient's home. And once we come out there, the team creates a plan of care for the patient. Normally, the registered nurse is the lead on the team, but is always working in collaboration with the primary care doctor. And we also have either our physician or our nurse practitioner that will come out as well and see the patient. All the medications related to the diagnosis that a person came to hospice is included, as well as access to 24/7 care. I mean, it's just a matter of calling us and we're able to guide the caregiver on this is what you do because mom can't breathe right now, or whatever the situation is. 24-hour access, and also all the medical equipment. So the hospital bed and the shower chair and all these other things, the oxygen, things that people may need to keep them comfortable, that's all included as well. And people will ask me, you know, can I keep seeing my primary care physician or being in contact with him or her? And the answer is absolutely yes. So what can we expect when one signs up for hospice care? Well, first of all, the team will come to the house. A plan of care is created for the patient based on the patient's needs and wants. And it's very patient-centered, meaning we want to know what are the biggest concerns for a patient and their family. And we want the plan of care to reflect that as well. The plan determines how often and who, with regard to our hospice team, will come to visit the patient throughout their time with hospice care. Now, many people don't realize, but people will graduate off of hospice care. They may get so much better that they no longer need us to come in and care for them. And so they graduate out of hospice care, and maybe months later, they may return to hospice care again. But it is amazing how we are able to extend someone's life when they understand truly what hospice care does. And it is to reduce, relieve, and maybe even eliminate terminal suffering. Now, there are some who might be at home and initially receiving hospice care, but maybe some of their symptoms are out of control and can't be managed at home, at which point they could come to our inpatient care center, Puhay Malama. Now, at this care center, this is not a long-term care center. Like, people don't stay here for years. It is a place where somebody comes to get their symptoms under control, and once that is managed, then they head on home to back to their families as well. Now, there are times where a patient's symptoms are not able to be managed at home at all, in which case the patient would remain with us in our patient care center. And most of the time, it's because the patient is progressing through their natural progression of the disease and will pass away at our patient care center as well. I'd say the average number of days that somebody stays at our Puhay Malama Care Center would be probably around 14 days. They either pass there or they get better and they go back home to their loved ones. So this is really a very specialized inpatient facility. Many people don't realize that the care for hospice is indeed covered by Medicare. However, if they come into an inpatient facility such as ours, the room and board is not covered unless somebody has additional insurance, particularly Medicare, because Medicare will cover the room and board portion of someone's stay at Puhay Malama. So that's a very important point to know. It's very sad when people want to bring their loved ones to Puhay Malama only to find out that they don't have the proper coverage to allow them to stay there for free. And so it is difficult for people to find out late in the game, meaning when a crisis occurs and then they have to bring them into our inpatient facility and are not able to because they don't have the Medicare coverage. It is advisable for you to look into that coverage now if that's something you think you might need later, or in fact that you could qualify for now as well, because it does take some time to get that application completed and done so people can get those benefits. How is hospice care paid for? So, as I've been saying to you, that those who have Medicare coverage or any kind of medical coverage, hospice care at home is covered 100%. So that is great news, that you can be with your family, you can spend your days with them and not worry about how am I getting this wonderful care, am I able to pay for it? It is indeed covered. So those who have other insurances besides Medicare, maybe they have Kaiser, HMSA, maybe they're under Veterans Administration and have Medicaid as well, they will all be covered for this hospice care at home. And again, if somebody needs to be in a nursing home facility or maybe a residential care home, or even if they need to come to Puhay Malama, if they have the additional insurance such as Medicaid, they will cover the room and board for their stay. So that's important to know. And it's important to plan for that now if that is not part of the plan yet. So it's better to do it before there's a crisis. What does the trained volunteers do? And we have trained volunteers that will come into the homes, and they are such angels. We absolutely love our volunteers because they come in and they spend time with the patient. They allow the caregiver to take a very much needed break. You know, whether the caregiver needs to run errands down to the store or the bank, or they need to go cut the yard, or they need to just go to sleep. They certainly can do that because we have a trained volunteer that can come to the home every week for a few hours and really help with pretty much anything. I mean, we've had volunteers that will go in, they'll make a sandwich for the patient, or they'll throw in a load of laundry. They've helped with doing some vacuuming. Some will even just take a patient out for a car ride because they just want to get out and, you know, go and look at the beach or just be out in the sun. And our volunteers pretty much are so flexible and accommodating in that way. So when somebody needs a friend, particularly when there's a terminal illness, oftentimes a lot of people are dealing with isolation, and it's because nobody wants to come to see them when they're terminally ill. And our volunteers are always the ones that will bridge that and spend wonderful time supporting the patient and the family. Now, moving on to our last and final program, and that is, what is bereavement care? So bereavement care is there to support anyone that has lost someone who has passed. So if there's somebody that is on hospice care, we provide bereavement care and support for up to 13 months after a loved one has passed. We also have a community bereavement group as well, which many people that are in one group will continue to come and be a part of the community group as well, which is a free peer-to-peer support group offered every Tuesday. And then we also have a children's bereavement group or plan available to people who may need that as well. And we go out to the schools and try to get those children who may need some bereavement support and guidance on how to deal with their grief in a way that will support them and help them going forward. So we find that bereavement is also a very important part of the continuum of care. Because when you think about it, when somebody gets seriously ill, palliative care comes on the scene, and we start to already help people feel better by providing relief for them. And then as the natural progression of the disease continues, there's hospice care, and we're there to really help, you know, mitigate any of that suffering and keep people comfortable at home with their loved ones. And then finally, to help the family who is there to support each other after the loss of a loved one. You know, when I look at hospice care, I see that hospice care is the Cadillac of all care and services. I liken it to a level of service. When I think about hospice care, I liken it to us going on a flight to heaven. So let's just think about this scenario of all of us are going on this flight to heaven. Some will go at 2 o'clock, some will go at 4 o'clock, some will go at 8 o'clock at night. Make no mistake, we're all going to go at whatever time we're supposed to go. Well, for those who are with hospice care, for whatever reason, that they signed up or they knew about it or they understood about it, all of those on hospice care and their families will go directly to the first class cabin. And the reason they'll go to the first class cabin in that airplane is because that is where all of the comfort is. Anybody that didn't sign up for hospice because they didn't care or they didn't know or they didn't want that because they were afraid of it, well, they don't go to the coach section of the airplane. They actually go to the baggage compartment of the plane. And the reason they go to the baggage compartment of the plane is because that is the coldest, hardest, just treacherous ride to the bridge that anybody is going to have. And sadly, not only the patient is going to go there, but all of their family as well. And we already know that the patient is going to transition over that rainbow bridge to heaven, but the family needs to come back on that flight. And that is a flight that brings you back. And many families will just break into a million pieces because they do not have the support. They were not resilient enough to be prepared for the passing of their loved one. And that's where bereavement care comes in, to really help pull families back together again so that they can deal with their new normal going forward. So I'm taking a look at our timing here, and we may have some time before Dr. Dolan comes in. I would like to ask if there's anyone who has any questions yet.
I don't see anything in the chat box yet, Lani.
Okay.
If anybody would like to unmute themselves and go ahead and ask a question, you may do so now.
Okay.
All right. I don't see any.
Okay.
Okay.
Let's continue. All right. So for those who are not familiar where our service area is, I wanted to share that Hawaii Care Choices goes from Laupähoehoe Point to South Point out in Ka'u. So we will cover all the points in between. So we'll go out to Puna, we'll go out to Pahoa, we'll go out to Mountain View, we'll go out to Papaiko. So it's important to know that when somebody needs help at home, we will go there and help service them. Now, there are other two.
Sorry, Lani, we have one question that just came in.
Okay.
If you can answer, who qualifies for Medicaid?
Okay, so that's a really good question. Normally, anyone who has a certain amount of income, it's normally offered to those who have a very limited amount of income. So the reason I bring up about Medicaid is because many of our aging parents live in their own homes, and that home is still under their name. So what happens is that because they own that property, they are then exempt from receiving Medicaid benefits. So oftentimes, many of the parents will move the ownership of that said property over to one of their adult children so that it's no longer under their names. And many times it's because the adult child is bringing their parent to live in their home. And so maybe that other home is being rented or whatever the situation is. But yes, Medicaid is completely and totally dependent on how much somebody makes. So if somebody is making more income, it's difficult to qualify for Medicaid.
Charlene, I see you unmuted yourself. Did you have a question?
Hi.
Hi, Charlene. Hi, Charlene.
Actually, I wanted to say that there's some guidelines for Medicaid, and that's a whole presentation
It is.
in itself.
It is.
And if people really want to know about that, maybe Legal Aid could or another organization can present that information in a tight question and answer, because it's complicated. Because
I think that's a great suggestion.
Yeah, but my question was for grief counseling.
Oh, okay.
Can it be someone who had a miscarriage versus someone who's had a loved one who died?
Oh, absolutely. Absolutely. Yes. In fact, people come to our grief counseling because they are dealing with a loss of any type. So, you know, when we had the lava flow and all of that, people that lost their homes came to grief counseling as well. So yeah, people lose a pet, some lose a relationship, some lose a job. They all count. So yes, absolutely.
Okay, thank you.
Mm-hmm.
The next question, Lani, is it Medicaid or Medicare that pays for Pohai Malama?
It's Medicaid. So Medicare will always cover the services that hospice provides. Those that care specifically is covered by Medicare.
Awesome. And Momi, just wanted to do a little thank you. Thank you, Lani, for all that you do and for your compassion and empathy for our community that we love. You are a gift to all of us.
Oh, Momi, I tell you, you're a check in the mail, Momi. You're so awesome. You're so awesome. Oh my gosh. And it was so wonderful to be able to do the focus on one of her sisters from their cancer support group, Debbie Kenui, who has such a beautiful family. And on Mother's Day, we were able to honor her. So that's great as well. I anticipate Dr. Dolan coming in from her office anytime, and you will see her picture pop up. And so once she does come in, then we will have a boatload of questions for her as well. Tish, is there any other question at this point?
No, but there is a lovely comment. From Shirley Long. This is an incredible presentation. Thank you.
Oh, thank you, Shirley.
As I believe somebody just unmuted themselves. Hi, go ahead.
Hi, Lani, this is Paulette. Aloha.
Oh, aloha. Oh, look at her. How wonderful. Welcome, welcome.
Yes, mahalo nui. I have a question.
Yes.
For, you know, as a patient per se.
Yes.
You know your diminishing health.
Yes.
And life. Can you personally request care at Pohai Malama? Or is it a PCP?
Yes, it's a PCP thing. Okay. And that's the primary care physician for all of you that aren't up on the lingo. You know, Auntie Paulette, she knows all the different lingo, so she knows. So yeah, that's right. Okay. Absolutely, Paulette. It would be a referral that's coming from your doctor.
Okay, mahalo. And you know, for everything you do for us, we aloha you and your whole crew. Mahalo nui, Tish.
Mahalo, Paulette.
Mahalo, Paulette. Awesome. That is so good. Okay, that's great. And you know, people do ask about Pohai Malama because if you've not been there, please let us know that you'd like to go for a tour, because once you see it, I mean, it is the Mauna Lani of hospice. And when people go there, you know, they want to make reservations, but it's not that kind of place. I mean, I have to personally say I would like to make reservations there too. I mean, it's just so beautiful with all the koa and the beautiful lush surroundings. It's such a home away from home, which is exactly how it was intended to be. So we're very, very happy to have it. And for the most part though, anyone going to Pohai Malama are normally very, very ill. So again, it's because symptoms cannot be managed at home that they need to go there. So, you know, to qualify to be there is a whole nother level with regard to being in hospice care. So that's why there is definitely a trade-off to be in that beautiful place. And we thought it was only right that people be treated like royalty when that time comes around for them. Tish, is there anybody else?
There isn't anybody else, but I just wanted to give everybody a sneak peek. So behind me on my beautiful virtual background is what I would like to be my home, but actually it is the family area of Pohaimalama. So as you can see, if I can move a little bit, we have a dining room table, a TV, beautiful artwork on the wall, couches, and lounge area. I really feel like I'm doing the news here. And just a really open space and very comfortable for those families that go there. Because like Lani said, when there are patients that are here, it's a very hard time for the family. So we want them to feel comfortable. And with that, Dr. Lynda Dolan just walked in.
Yay! Yay! Okay.
Yay!
Okay. And we're going to have a session of Let's Ask Dr. Lynda Dolan. So do you have her screen up? Oh, okay. So we're going to ask, Paulette, I see that you're muted. You can also turn your video off too. Then you can see Dr. Dolan.
Hello.
Oh,
Hi,
there
Dr.
she is.
Dolan.
Okay. Okay, very good. Can everybody see Dr. Dolan? Yay. Okay, awesome, awesome. So we are so very happy to have Dr. Dolan today, who is a palliative and hospice care specialist, and she's a family physician as well. So she's very, very aware of our different services at Hawaii Care Choices, largely because she is the medical director. So we are very happy. Thank you so much, Dr. Dolan, to be with us today.
Well, thanks for having me. I know for me, this is a little weird talking to a screen, and I'm getting used to it just like everyone else is, so.
That's good. So it looks like you're coming to us directly from your medical practice.
Yep, in the exam room. So I just wanted to make sure that it wasn't too echoey, because I could put headphones on if we need to.
No, it sounds okay.
Okay.
It sounds okay. All right, great. Well, let's start getting some questions there for Dr. Dolan. Tish, you can go ahead and handle that now.
Okay, I will. We're just going to let everyone take a few moments to type it in. Lani, did you have any pre-submitted answers? I know we had some of those in when people registered.
Answers, what do you mean?
Oh, questions. I'm sorry.
Oh,
Questions. So sorry.
Like, okay, what was that? No. No, actually, I passed them all over to you. So if there's any that you want to go ahead, you can lead out with those questions, and then as people type theirs in, then we can just weave those questions in for Dr. Dolan as well. Okay,
that sounds great. Let me just take a few moments to get those.
I just wanted to say hi. I see a couple of people's names that I recognize, so I just want to say hi to you all. I hope you're doing well.
So we're asking everybody to be off their video because we are recording the entire session.
Oh,
so
God.
just letting you know, Dr. Dolan. I mean, no pressure, but this is what we're doing.
I didn't have my hairdresser. I haven't had a haircut in 2 months, so.
We are all in this together. Yeah. All right, Dr. Dolan, someone had pre-submitted this earlier, and the question is, my dad is 90 and my mom is 85 with dementia. My dad says he's my mom's caregiver, but he's pretty frail too and is diabetic. They both live on their own, in their own homes, and I visit every other day to cook and make sure that they have food, wash the clothes, and clean up. I'm pretty burnt out. Do you have any suggestions on how I could get help for my parents? They also don't like going to the doctor.
There's lots of things and support out there, and I guess I'm going to again speak from the terms of Hawaii Care Choices and what programs we have, as well as what my background is in terms of learning about hospice and palliative care over the years. We know in terms of care of patients as they get older, or even when they're younger and have a serious illness. There are lots of things that happen, and it really takes a team in order to help take care of them. And our goal with our elders in our community, kapuna as we call them here, is to sort of honestly keep them at home and keep them safe, because that's the best environment they love to be in. And moving them to facilities sometimes has to happen, but sometimes not if we're creative. The term and the team called the Palliative Care team, our program called Kupu Care, is something that brings together many multiple different disciplines. One is a physician, but honestly, the physician is not, or a nurse practitioner, honestly, is not the biggest part of the team. To me, the biggest part of the team is a nurse, a social worker, and a spiritual person. And what those people have that is absolutely fabulous is they're able to go into the home, assess them, as well as the contacts that they have way out in the community of resources that can be brought into a person's home to, one, keep them living functionally as much as possibly and safely in their home as they age, as I call it. The other thing is if people have increasing needs, healthcare needs, or been in and out of the ER, the nurse then helps look at where their medical story is, for lack of a better term, and then works and communicates either with a provider, a physician, or a nurse practitioner in the Hawaii Care Choices team, and or their primary care physician, even if they don't want to go see the doctor. The other new thing, which is brand new, is, which was before this coronavirus thing, but actually accentuated it with the coronavirus, is we're able to visit with patients in their home now with technology, which we couldn't before. So even if not everyone can get there, we can organize a meeting between the patient's doctor and the patient in their home, which is astoundingly great and very powerful and a lot of information. So that's kind of what I would call the ground level of what we could do for this example with this couple. And I didn't even mention relieving some of the stress from the child, the adult child, who is also trying to manage this and probably juggling their own family and their own job, and feeling comfortable with other people helping out.
That is wonderful. Thank you, Dr. Dolan. Another question is, my husband is diagnosed with lung cancer. Should I get palliative care for him even though he doesn't have any symptoms? And if yes, when should he get that care?
So an absolute yes on that question. Palliative care is, some people think, oh, you have to be really sick, or for hospice, you have to be really dying. And that's only partially true. The goal of people when you unfortunately get what I call a life-limiting or life-changing diagnosis is when you need palliative care. It's when you're first told, honestly, the bad news. Yes, you still need those specialists, whether it's the oncologist, the heart doctor, and your primary care provider, still are all on your team. And all of those providers have special skill sets, whether it's the oncologist to manage the chemo and knowing what the next treatment should be, or it's the primary care doctor making sure you manage the blood pressure and your cholesterol because you're still living and breathing and wanting to fight and live. The palliative care portion of it brings in, again, that team that I just described, and looks at what your needs are at this time, which may be not a lot. And it might be just, hey, how do I get back and forth transportation to my oncology treatments? Or am I eligible for some grants or some support in the home because my electric bill has gone up because I'm using oxygen more? Then if your symptoms, we hope not, but if it happens, they start to become worse, meaning you have more pain, more difficulty breathing, that palliative care team taps into the medical aspect of the nurse practitioner, the physician, to get some advice or some ideas. They then help treat and can go visit you also in the home, and or they help guide your primary care physician and the oncologist along the way. And I always say we're all pieces of that healthcare puzzle. And yes, we all fit together, but sometimes it's a dance of trying to move those pieces and puzzles around to find the right fit. And as you go through this, what I call journey of the diagnosis, hopefully with a good ending of cure, there are ups and downs with symptoms, pain, shortness of breath, emotional component, spiritual component that change on that disease trajectory that the team can help with. So the sooner the better is my message.
Awesome. My grandmother has COPD and has lived with it for over 20 years. Should she get palliative care even though I'm not sure she needs it? And how would she benefit from it now?
So the answer again is a big resounding yes. There's a couple of reasons. One, the disease process of COPD is a disease that never goes away. And we know scientifically it will progressively get worse. How it progressively gets worse, we can't totally predict, but we watch and monitor with the patient and can kind of see how things change. In addition, if most people who are a grandmother are usually, not all the time, but usually above the age of 50, 60 or so, so they're on the advanced age spectrum, which that in of itself adds another dimension of their disease process. And figuring out how to live safely in the home, if then there's need for oxygen, those are things that are identified with the care team to figure out how best to manage. And there can be, unfortunately, times when grandma gets sick with pneumonia, may end up in the hospital. Those transitions from home to the hospital to maybe a skilled nursing center, or back home with skills in the house, because that's where people want to be. They want to go home when they're done with the hospital usually. The palliative care team actually can help those transitions, because it can be very challenging as the family member dealing with all of these, again, pieces of the puzzle. And having someone assist you is very, very helpful, because as a lay person in the community, you don't know the lingo, the language sometimes, or the different resources. And the team kind of walks with you to help you, one, learn the language, or two, at least what I call decipher and translate the language for you and get the things that grandma needs. And at the same time, another part of the conversation is talking to grandma about what her goals are, what she wants out of life, what she wants out of her health care. And sometimes what we, as younger members of the family, want for grandma's health care is not always what grandma wants. And sometimes it's hard to talk about it. And having the help of palliative care team members who are really trained and schooled in those, guiding those conversations, not making the decisions for the loved one or for the family, but guiding that walk, that conversation, can be very helpful. Because as a loved one, you may not agree with grandma, and it may be hard, and you want to push her, keep doing it, but grandma doesn't want to. The palliative care team can help. Say, if it's me pushing, say, okay, Lynda, back off. Is it your goals or is it grandma's goals? And let's support grandma's goals.
Yeah.
Even though it can be really hard sometimes.
That is a great answer to that question. Thank you, Dr. Dolan. Another one is my Filipino auntie doesn't want to sign up my uncle for hospice because she's afraid of his ghost, that if he dies in their home and they are Catholic. Is that true?
Well, I'll disclose that I'm Catholic as well. And I don't believe that ghosts come and visit us afterwards. I think there is a lot of elements of spirituality and religion that interplay with our journey on life. And sometimes I think there are unsaid things or things that weren't closed out that we struggle with after our loved one is gone. And it comes back to us in our brains in certain fashions. And I don't want to refute people who feel that there are ghosts and spirits that come visit afterwards. But I think that to me is a sign that there are things that are unsettled. And again, the palliative and hospice care team are responsible for bereavement afterwards. And that journey for a year after the person's passing is part of the benefit. In addition, we've had experiences like that, and we've brought in the religious person of choice for the patient and done different ceremonies in order to make sure that everyone feels comfortable. And some of it is almost feeling like you have permission to be able to do this. And whether it's the priest or the bishop or whoever, whatever your spiritual and religious beliefs are, come to give us that guidance, that seems to help a lot. And we really want to know about those fears before the person passes, because really that's stuff that we can deal with and settle in a more comfortable way beforehand. But there's always things after that we struggle with when someone passes that we would continue on with.
Yeah, yeah.
Thank you. Next is, if my mom agrees to hospice care, does that mean death is near, and is she giving up on life?
No, no, no. It's a perception of hospice. You go into hospice and you die fast. I would counter and say that people are not referred to hospice soon enough. And that's why they die fast, because it's you're on the last few weeks, the last legs. And this is why it's so important to make it more open and normal to have conversations about our fears about dying, our fears about, is the treatment going to work or not? And that's that whole moving up this, what I call upstream with palliative and hospice care, to get people in sooner. Now, there are some rules of the games with insurance companies that with hospice, you can't be receiving aggressive chemo, aggressive cardiac workups and things like that. So unfortunately, we're limited, which very frustrates me. And some people want to do everything right till the end. Yeah. So, okay, then if that's what their wish is, then the palliative care portion still can help. And there's still benefits that we have in Hawaii Care Choices. There's a few programs that we're very blessed to have with some of our insurance companies. One is called Supportive Care with HMSA. Another one is called Concurrent Care, which is a VA benefit. You have to be a VA person to get that. And then there's another one with United Healthcare. All very similar, that you can receive the support services of palliative care and hospice, and I use the term hospice-like because you can still get that aggressive management, what I call acute medical management, while still receiving comfort-directed medical management of hospice and palliative care.
So that means that they can keep getting treatments while being on supportive care?
Yeah, yeah.
Okay.
Yep, absolutely. And we kind of walk the walk with them. And if the treatment's working, hallelujah, and you get better, and we call it that you get discharged from, so I call it a live discharge from supportive care. And we've had live discharges from hospice as well. Mm-hmm. Yes. And we say, go celebrate. And because, the one thing that we always keep is hope. We never relinquish that hope.
Wonderful. This is another great question about palliative care. What does a palliative doctor do that is different from what my other doctors are doing? And will I no longer see my cancer doctor? And will I need to stop treatments?
Okay. So palliative care can be done by a physician and a nurse practitioner. It is an add-on to the services of what you're receiving. We do not replace anyone. And the goal is, again, back to my idea of puzzles. There's pieces to the puzzle, and we can actually add more pieces as we go along. But we all have what I call our niche, our specialty. So I'm not an oncologist by no means, and I can't keep track of all those medicines. But an oncologist is on my team when I'm taking care of the patient. But the oncologist doesn't know that I have some tricks and tools in my bag of medications and that are used to, again, relieve those comfort-directed symptoms that people have. And then your primary care physician may or may not know about some of these secret medicines. They're not really secret. We just use the same medicines we all do, but in different ways. And then we work together, because I may not know, and I'll know from the primary care perspective that this patient has a fear about morphine. And then that PCP lets me know that, so then I can direct my conversation a little bit more to ask, what are your fears? How can we help? That sort of thing that maybe the PCP would not have the time to do. but they're still all involved with that. And I know palliative care sometimes is a hard thing for people to grasp because it's really an overlay to what you're already getting. And we kind of, I describe it as there's a forest and there's trees, and the trees are kind of your medical issues, and the doctors do various tree trimming of those trees. The palliative care doctor's kind of more on the ground and looking at the roots and kind of all over the place, and not necessarily totally getting in the way of those people who are trimming the trees, those doctors, but catching the branches as they fall or placing them in a place that's more conducive, which is that symptom management and stuff. So it's all together that we do it. Now, I must admit, as a physician and dealing with some of my peers, they have trouble understanding it as well. And I present it to the physician, my fellow peers, is that, are you struggling with this patient and feel like you can't totally provide everything that they need? And when they say yes, I said, you need palliative care, because it's an added layer on to help you walk the walk with this patient and help guide you, but you're still the leader of the pack.
That's great,
It's
Dr.
wonderful.
Dolan, that you define that, because I think people get confused as to why would I need palliative care because I already have a doctor. So that's great. That is that extra layer that people will have when they sign up for palliative care.
Right. I always use the example, why do I need a cardiologist? Why can't my PCP do it? It's the same concept. If you've had a heart attack and you need a heart catheterization, your primary care doctor can't do it, so you utilize the cardiologist. No different than the primary care doctor doesn't know exactly how to manage your nausea, the palliative care doctor knows how to do that. So I say we use our brain as our tool, no different than the cardiologist who does the heart catheterization. They use their hands to open up those arteries and stuff. They use their brain too, don't get me wrong, but.
This question is from mentioning the morphine. I know pain medication helps to keep one comfortable, but will it hasten their death too?
So that answer is yes and no. So the first part is, the answer is no. It usually does not hasten anyone's death. It does not diminish your breathing rate if dosages are used appropriately. And sometimes what happens is we as physicians clearly underdose because of our experiences with the medication before, and honestly, because of pressures that we get from various entities, meaning the government and that, because they put mandates out and sometimes they confuse us. And I don't mean it rudely of the government or anything, but it can be really a challenge to work through their requirements and stuff. When dosed appropriately, morphine can give dramatic relief to people who have breathing difficulties in very, very small dosages, as well as improve patients' pain if they're having pain from cancer pain, they've had a broken bone pain, those sorts of things. But again, it has to be used appropriately and monitored in probably a tighter fashion than honestly going back to the palliative care team, the oncologist or the PCP has time to. So the nurse or the palliative care doc can be calling the patient almost every day. How's your pain today? What did you use yesterday? And let's readjust it accordingly, okay? Now, the other part of the answer is yes, is sometimes at the end of life, people are struggling. They are struggling. I call it, we're here, they're in the middle, and they can't get to wherever they believe is the next place to be. They're stuck. And it's because they're tense, they're tight, there's something holding them back. And morphine and another medicine, lorazepam, are two very good medicines that relax the pain, relax the anxiety, and allow the patient to feel calm and restful, and then they're able to fly. Mm-hmm. And so I think that's where morphine has gotten its bad rap in terms of that. They gave them a dose of morphine and they died. Well, usually it's a small dose of morphine, it relaxes them, and then they are able to go wherever that next place is that they need to be. So that's kind of where that is.
Thank you so much, Dr. Dolan, for answering all these questions that came in. I have one more. It says, I think my mom could benefit from hospice care. If I called Hawaii Care Choices, would you contact her primary care physician to get the approval, or would I need to do it myself?
Okay, so anyone can refer themselves to hospice care. Usually what we try and do, because we have so many different more programs than we did before, what I really say is just call Hawaii Care Choices. Our staff knows the different programs that we have, a little bit of information about your mom, their insurance, and maybe what the goals are. Even if you have goals besides, I don't know, I just need help, then our team kind of helps and asks you more questions, and then we look at what they would be beneficial of in terms of the different programs. Then we contact the primary care provider, because it is very prudent and a pretty staunch thing of mine that all the primary care docs know what's happening with their patients. And so we call them and we say, do you think, we kind of educate them on, okay, we think your mom is appropriate for supportive care. And so we would send them or call them, fax them or pick up the phone, because we still pick up the phone, because I think that's important, and say, your mom is eligible for supportive care because of X, Y, and Z. Do you agree? I haven't had a primary care physician say no yet.
Mhm.
Sometimes they're like, oh, I didn't even know that program existed. And then what the hospice and palliative care team has to do is then double check and look at the medical information to make sure they meet all the criteria for the program, whichever program it might be. With hospice, the CMS gives us guidelines that we follow. Not everyone fits exactly into the guidelines, and we're able to create what I call paint a picture of the patient in order to make sure that they meet all the criteria in a fashion that Medicare agrees with in that. And I must say, I have had this example, and I don't mean to be negative. We have had some families who say, please don't contact my primary care doctor. And our team asks, well, is there a reason why? And then we kind of dig in a little bit to if there's some friction or something like that. And then we actually will act as the go-between between the family and that physician. And sometimes I personally will call them up and say, you know, they're not happy, or they were unhappy about this. What do you think? And so either try and mend fences or realize that, okay, that just wasn't a right fit. Because I do believe my mantra is always there's a doctor for every patient and there's a patient for every doctor. And sometimes along our trajectory of healthcare, we don't match up as well. And no one should stay with someone that they're not comfortable with, because their healthcare then is compromised because of it. So.
Thank you, Dr. Dolan, for answering all those questions and just for taking your time out of your busy day to be with all of us. We have about 4 more minutes left on this presentation, and I wanted to open it up to anybody if you would like to comment in the chat box below, or go ahead and unmute yourself if there is a comment that you would like to give Dr. Dolan. You could do this at this time, sorry.
Hi, this is Shirley.
Hi, Charlene. Go ahead.
Dr. Dolan, how do you work with the resources at the Aging and Disability Resource Center for caregiving and caregiver burnout? There was a question earlier in the presentation. Just wondering.
So in regards to any of our programs, the social worker is I call it the king or queen of that, because we do have male and female social workers at Hawaii Care Choices, which is great. My personal bias is the social workers are the bomb, because they know all of these resources. And if they don't, they go and search. So they have pretty good relationships with the ADRC, as well as other, the food bank, Helco. I mean, there's all kinds of networks that they have. I'm like, how do you even know about some of this stuff? I mean, even to the point of some of the shelters for women who are in relationships and need to get out. I mean, there's all kinds of resources and contacts that they have. It's kind of like their secret list, and they don't necessarily share it with me, but they have the contacts in that. And then some of it, now the social worker can't necessarily do everything for the patient because there's rules of the game in regards to that, of asking for support and caregiving at the home. But they really walk the walk with them, bring the paperwork home to the family, you know, those sorts of things in order to push it along. They also even look at, and this is kind of going a little bit beyond, is looking to see if they qualify for Medicare not Medicare, sorry, Medicaid, which adds more benefit to the patient. And they help walk them through that as well if they're eligible, because then that opens more doors for resources for them. Does that answer it, Charlene, for you?
Yes, thank you.
Okay.
Dr. Dolan, I got a comment in that says, this has been an incredible reinforcement for me concerning Kupu Care and hospice. Thank you so much for keeping this information available and in the community.
Thanks, Bua. I always say, when in doubt, just call us. And, you know, I want to be able to one day say, call us and we can manage all of it. And we have no roadblocks or barriers. Because right now there are some roadblocks and barriers. Some of it is with patients and docs and stuff, but the bigger barriers that I stress over now is with the insurance companies. And I assure you, we are continuing to move forward with that. And that's why I'm so happy that we have relationship with UHC, HMSA, and the VA. We didn't have those relationships a year ago. And so this is finally, people are seeing the benefit of palliative care. And again, it's not acute care and then comfort care. It's the trajectory. It's not black or white. It's black to gray to white maybe. And we should be able to have this whole spectrum that's available for every one of us overall.
I have a question, if I may.
Go ahead.
Okay, with cancer, a reoccurrence or metastatic, management of this, when it gets to that stage, well, I just wanted to know, to give hope to other group members, but does it diminish your lifespan or hope?
Okay, great question, Paulette. So in terms of oncology world, metastatic disease is not a death sentence anymore. There are so many new medications out there that allow people to live a really good life if their cancer matches up with these new immunotherapies and things like that. You know, I had a patient who just recently passed, and it was 10 years from her diagnosis of metastatic lung cancer, and she wasn't a smoker. And 10 years ago, I said to her, wow, this is bad news. You need to be in hospice. I was totally wrong. And she lived a very full life for 10 years. Granted, you know, some medicines stopped working and then she had to use other ones, but you continue along the disease trajectory and you always have hope. So even in my practice, I definitely have readjusted how I manage and speak to people when I discover disease that is spread, because there's so many more options out there. And that's part of I think the help with palliative care in that is that they can walk the walk with the patient and be an advocate. And also, you know, cheer up the patient and say, okay, you know, maybe you're down on your luck a little bit right now, but you know, there's these other trials, there's these other things. At the same time, that sometimes those treatments do cause a lot of untoward, not very pleasant symptoms. And sometimes they're really bad. And then you have to decide, is it worth all these symptoms to try and live a little bit longer? And that's where the quality of life comes in that. So, yeah, so hope is still there no matter what. And I always think there's hope even when people are dying, because there's hope that they go someplace that's wonderful for them. There's hope left for those who are living, because we've, you know, I took care of my father-in-law who passed of pancreatic cancer. Sorry. And the best job I did was care for him I learned so much. And it was a hope and it was a gift that they gave us. Yeah. Hardest job I ever did, though. Harder than medical school.
Thank you so much, Dr. Dolan, for answering all the questions and for your vulnerability and great work in caring for others in the community. We really appreciate your time. And we would like to thank Lani for presenting on all of the choices that we offer at Hawaii Care Choices. Thank you. Thank you for all of the participants who have joined on this call. We will be doing a follow-up survey when this is concluded. As we said in the beginning, this presentation is being recorded and will be available for later access as well. And that information will be out to you shortly, or if you can visit Hawaii Care Choices on Facebook, that information will be there as well. Please feel free to put any additional comments in your surveys when that gets sent out too. We would love to hear your comments on what you think about our presentation, how we can improve, any comments for Dr. Dolan as well, and we can hand that over to her. So again, aloha everyone, thank you so much. Thanks again, Dr. Dolan and Lani, thank you again.
All right,
Take care, everyone.
Aloha.
Thank
Aloha.
you. Thank you.